Bonjour à tous et bienvenue à PodBites, le podcast où nous étudions des sujets médicaux complexes en petits bouchées. Parfait pour vos trajets, vos pauses au café ou chaque fois que la curiosité vous appelle. Je suis Abdelrahman Lachize, votre animateur pour l'épisode d'aujourd'hui et je suis accompagné par Omar Kobrosly.
Kifkom bros, ça va? Welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for commute, coffee break, or whenever curiosity calls. I'm Omar Kobrosly, and I'm joined by Abdelrahman Lachize. We're covering the pathology of CNS tumors.
Before we dive into individual tumor types, we need to understand the general behavior of CNS tumors because they follow patterns that are very different from tumors elsewhere in the body. When we talk about CNS tumors, we're referring to tumors that can arise either within the brain itself or within the spinal cord.
Yes, intracranial tumors are significantly more common than intraspinal tumors. In other words, tumors of the brain occur far more frequently than tumors of the spinal cord. They really show us where most of the clinical focus is when it comes to CNS tumors.
Another thing about CNS tumors is that their location strongly correlates with the patient's age.
For example, in children, most CNS tumors arise in the posterior fossa. The posterior fossa is a region that contains the cerebellum and brainstem. So when a child presents with a brain tumor, you should immediately think about tumors in this region. In contrast, in adults, most CNS tumors arise in the cerebral hemispheres. These are large upper portions of the brain responsible for higher cognitive functions, motor control, and sensory processing.
So adult tumors are typically supratentorial, which means in the upper brain, while pediatric tumors are commonly infratentorial. If different age groups get tumors in different locations in the brain, does that mean the type of the tumor is also different?
Yes, age is an extremely important diagnostic factor in CNS tumor. Certain tumors are almost exclusively seen in children, while others are primarily seen in adults.
One of the key differences between CNS tumors and tumors in the other organs is the absence of detectable premalignant lesions.
This is very important. You know how many epithelial cancers like colon cancer or cervical cancers start out as some dysplastic lesion or carcinoma in situ, then become malignant?
I'm guessing that's not the case for CNS tumors, right?
Exactly. They usually present without a clearly identifiable precursor stage.
This means CNS tumors can sometimes appear suddenly from a clinical perspective, without the warning signs that we commonly see in epithelial malignancies.
Yeah, pretty much.
Another major difference is that CNS tumors rarely metastasize outside the CNS.
Yes, unlike cancers such as lung cancer or breast cancer, which frequently metastasize to distant organs, primary CNS tumors usually remain confined within the central nervous system. They can move through the subarachnoid space, which is still inside the CNS. However, this does not mean they are harmless.
I feel like it doesn't always matter if it's benign or malignant. I mean, of course, there's a potential to metastasize, but the skull is such a confined space, anything growing in there can take up space you can't really afford, and that could cause many issues, even if it's a benign mass.
Yeah, that's true. In the CNS, it's not just whether it's benign or malignant that matters, but the tumor's location can be just as important. There is very limited space for expansion within the skull. Even benign or slow-growing tumors can cause devastating clinical effects if they compress vital centers of the brain. They can increase intracranial pressure and cause severe neurological dysfunction.
This is why the clinical impact of CNS tumors depends not only on the histologic grade, but also on their size and location.
Location is very important.
CNS tumors also tend to recur.
And when they recur, they may reappear as high-grade tumors. This means that the tumor can become more aggressive if they come back. That's why long-term monitoring of CNS tumor patients is very essential.
There's yet another distinction that we need to understand in CNS tumors, and that is whether a tumor is intra-axial or extra-axial.
An intra-axial tumor is a tumor that arises within the brain tissue itself. These tumors originate from cells that are part of the brain parenchyma, such as astrocytes, oligodendrocytes, or ependymal cells. In contrast, an extra-axial tumor arises outside the brain tissue. These tumors originate from structures surrounding the brain, rather than from the brain itself.
Examples of extra-axial tumors include tumors arising from the meninges, such as meningiomas, as well as tumors arising from cranial nerves. We can distinguish intra-axial or extra-axial tumors in radiology.
When radiologists evaluate imaging studies such as an MRI or CT scan, One of the first questions they ask is whether the tumor is intra-axial or extra-axial.
Since our main goal is to look at the brain tissue, we're mainly going to use MRI, right?
Yeah, MRI is the most important imaging modality because it provides detailed visualization of brain structures and allows us to assess tumor location, size, and extent.
And we can enhance the MRI image with contrast to evaluate tumor vascularity and detect small lesions.
We do have some advanced imaging techniques like MR spectroscopy, which allows us to analyze tumor metabolism, as well as the PET scans, which helps differentiate tumor tissue from necrosis or treatment-related changes.
Despite all these imaging tools, definitive diagnosis always requires biopsy and histopathologic examination.
Exactly. Histopathology is the gold standard. You cannot treat a CNS tumor without obtaining tissue diagnosis. Microscopic examination allows us to identify tumor type, grade, and molecular features.
We do have some specific histologic patterns for CNS tumors that give us important clues about the tumor's origin and behavior. One of the first patterns we need to recognize is something called a whorl. Kobe, what exactly is a whorl?
A whorl is a circular arrangement of tumor cells that spiral around a central point, almost like layers of an onion. This pattern reflects organized growth of tumor cells and is especially characteristic of certain extra-axial tumors, particularly meningiomas. When pathologists see whorled arrangements under the microscope, it immediately suggests tumors that originate from the meninges rather than the brain tissue itself.
There's also something called samoma bodies.
Yeah, those are just layers of laminated calcium.
Another extremely important histologic structure is the rosette. This is a pattern that shows differentiation toward neural or neuroectodermal tissue.
A true rosette is formed when tumor cells arrange themselves in a circular pattern around an empty central space, which represents an attempt by tumor cells to mimic a neural tube-like structure. This reflects neuronal differentiation and is commonly seen in tumors like medulloblastoma and other embryonal tumors.
Closely related to that is something called a pseudorosette.
A pseudorosette looks similar to a true rosette, but instead of surrounding an empty space, the tumor cells surround a blood vessel. The cells radiate outward from the vessel, creating a spoke-like pattern. This pattern is especially characteristic of ependymomas, since these tumors arise from the ependymal cells that normally line ventricular surfaces and interact closely with cerebrospinal fluid and vascular structures.
So overall, recognizing patterns like whorl, rosettes, and pseudorosettes is how we tell exactly what type of tumor we're looking at. Let's connect the dots with a clinical scenario. A 7-year-old boy presents with headaches and balance problems. Imaging reveals a tumor in the cerebellum. Based on what we've discussed so far, what conclusion can we already draw?
First, the patient is a child, and the tumor is located in the cerebellum, which is infratentorial, in the posterior fossa. This fits the classic pattern of pediatric CNS tumors. Second, the tumor is located within the brain tissue, making it an intra-axial tumor. Based on the patient's age and tumor location, we can begin narrowing the differential diagnosis even before histologic confirmation.
I would say we covered the basics pretty well. Let's start talking about the actual tumors now. How exactly are these tumors classified?
CNS tumors are classified primarily based on their cells of origin. This means we categorize tumors according to the type of normal cells they arise from within the central nervous system.
And since the CNS contains multiple specialized cell types, this leads to several distinct tumor categories.
One of the most important categories is tumors of neuroepithelial origin. These tumors arise from cells that are part of the brain tissue itself, including astrocytes, oligodendrocytes, ependymal cells, and neurons.
Since these cells are part of the normal brain parenchyma, tumors arising from them would be intra-axial, right?
Yes, exactly. Neuroepithelial tumors are typically intra-axial tumors. This group includes some of the most common primary brain tumors, such as astrocytomas, oligodendrogliomas, ependymomas, and embryonal tumors like medulloblastoma.
Okay, so neuroepithelial tumors are pretty common. Another major category includes tumors originating from the meninges, such as meningiomas.
Meningiomas arise from the protective coverings of the brain rather than the brain tissue itself, which makes them extra-axial tumors.
Then, there are tumors that arise from cranial and spinal nerves, such as schwannomas, which originate from the Schwann cells.
We also have tumors of the cellular region, such as pituitary tumors and tumors arising from germ cells.
And finally, an extremely important category is metastatic tumors.
These tumors do not originate in the CNS, but instead spread to the brain from cancers elsewhere in the body.
Which cancers usually metastasize to the brain, Kobe?
They're most commonly coming from the lungs or breasts.
So basically, if we know what type of cell a tumor arises from, we can predict its behavior, and that will guide us through our treatment decisions. Now, let us go into each type of tumor in more details. Starting with the most important category of primary CNS tumors, gliomas. If you remember nothing else from this episode, remember gliomas, because they are the most common group of primary tumors in the CNS.
Gliomas originate from the precursor cells that differentiate into glial cells.
Glial cells are those supporting cells of the nervous system. These are not neurons themselves, but they are essential for maintaining neuronal function, structural stability, and metabolic support.
Exactly. Glial cells include astrocytes, oligodendrocytes, and ependymal cells. Tumors arising from any of these cells are considered gliomas. We then classify gliomas based on which of these cells exactly they most resemble. One of the most important principles in glioma pathology is grading. Gliomas are classified into different WHO grades based on how aggressive they look under the microscope. These grades reflect tumor biology, growth speed, invasiveness, and prognosis.
What is the grade based on? What do we look at?
In CNS tumors, the grading criteria are based on features like cellularity, nuclear atypia, mitotic activity, necrosis, and endothelial proliferation. We actually don't use necrosis and endothelial proliferation as an indicator for grade in any other type of tumor other than in the CNS. Necrosis and endothelial proliferation are especially critical because their presence automatically indicates a grade 4 tumor, which is the highest level of malignancy.
So grade 4 equals necrosis and endothelial proliferation. That means this tumor is really bad.
A grade 4 astrocytoma is also called glioblastoma, which is the most aggressive glioma by far. But don't worry about that now, we'll come back to it later. For now, just remember the features that determine the grading criteria.
Those are cellularity, nuclear atypia, mitotic activity, necrosis, and endothelial proliferation.
EWA, and that grade 4 equals necrosis and endothelial proliferation.
This is all based on what the cell looks like under the microscope, but there's also classification based on molecular markers.
Yeah, for example, mutations in the IDH genes are extremely important. Tumors with IDH mutations tend to have a better prognosis compared to tumors without this mutation.
So basically, IDH mutations equals better.
Now, we use both types of classification. Modern CNS tumor classification combines the histologic appearance with genetic features and molecular markers to produce a more accurate and clinical meaningful diagnosis.
The first type of glioma that we're going to talk about is astrocytoma. This is a major group and is actually the most common type of glioma.
Astrocytomas arise from astrocytes, hence the name.
Astrocytes are those star-shaped glial cells that support neurons and help maintain the blood-brain barrier.
One of the most important diagnostic markers of astrocytomas and glial tumors in general is GFAP, or glial fibrillary acidic protein.
GFAP is a protein found within astrocytes, and its presence confirms that a tumor is of glial origin.
GFAP is very important because it makes us sure that we're looking at astrocytomas and nothing else.
Okay, so GFAP equals astrocytoma.
After we find GFAP and decide that we're looking at an astrocytoma, we can now decide whether it's a localized astrocytoma or diffuse astrocytoma. Localized astrocytomas are typically well-circumscribed tumors and occur mostly in children. Diffuse astrocytomas, on the other hand, are infiltrative tumors and occur most commonly in adults.
So basically, localized are in children, while diffuse are in adults. The symptoms of astrocytomas vary depending on where they occur in the brain.
If the tumor is located in the cerebral hemispheres, patients often present with seizures, headaches, weakness on one side of the body, difficulty speaking, or behavioral changes.
These symptoms occur because the tumor disrupts normal cortical function.
If the tumor occurs in the cerebellum, patients typically present with ataxia, which means loss of coordination and balance.
This happens because the cerebellum is responsible for coordinating movement.
If the tumor occurs in the brainstem, patients may develop cranial nerve deficits such as facial weakness, difficulty swallowing, or vision abnormalities.
And this reflects the critical role of the brainstem in controlling cranial nerve function. Now, let's focus on pilocytic astrocytoma, which is the classic pediatric glioma. So remember, P in pilocytic stands for P in pediatrics.
Pilocytic astrocytoma is a grade 1 tumor, meaning it's the least aggressive astrocytoma. It occurs most commonly in children and young adults, and is typically located in the cerebellum. The classic gross appearance of the tumor is a cystic lesion with a mural nodule. The cyst appears as a fluid-filled cavity, and the mural nodule is the solid tumor component attached to the cyst wall.
This gross appearance is usually how we recognize the tumor in radiology.
Now, if we zoom into the histology, we would find that the tumor cells are bipolar astrocytes with long, thin, hair-like processes. This hair-like appearance is actually where the name pilocytic comes from. Pilo meaning hair.
Oh, that's perfect. You can remember the cyst on gross morphology because pilocytic sounds like you're saying pilocystic. And you can remember the hair-like processes on histology because the pilo in pilocytic stands for the hair follicle.
Oh yeah, I like that. Other than those features, a very important structure seen on histopathology are rosenthal fibers. Rosenthal fibers appear as elongated bright pink structures under the microscope. They represent abnormal accumulations of protein within the astrocytic processes. These fibers are a hallmark feature of pilocytic astrocytoma, indicating a more low-grade type of astrocytomas.
We said there are hair-like processes and rosenthal fibers, but there are also eosinophilic granular bodies, which appear as round pink granular structures scattered between tumor cells.
Yeah, these structures represent degenerative changes within tumor cells and are commonly seen in pilocytic astrocytoma.
Pilocytic astrocytomas are relatively well circumscribed tumors. They are actually the grade 1 astrocytomas.
Yeah, they do not infiltrate surrounding brain tissue extensively. That's why they can often be surgically removed completely.
So, pilocytic astrocytoma actually has an excellent prognosis.
Luckily, yes.
This is one of the most important distinctions between grade 1 astrocytomas and higher grade astrocytomas. Grade 1 tumors like pilocytic astrocytoma are localized and slow growing. Higher grade astrocytoma, which we'll discuss next, are infiltrative and much more aggressive.
Localized tumors tend to remain confined and are more treatable. Diffuse tumors infiltrate normal brain tissue and are much harder to eliminate completely.
Now, let's shift from the localized astrocytoma, aka pilocytic, to the more diffuse ones.
Unlike pilocytic astrocytomas, which are well circumscribed, diffuse astrocytomas are infiltrative. This means they invade and spread into the surrounding brain tissue.
On gross morphology, these tumors are ill-defined. Instead of forming a neat, well-contained mass, the tumor blends gradually into the surrounding brain. This blurred boundary reflects its infiltrative nature.
And this infiltrative behavior is exactly what makes diffuse astrocytomas so dangerous. Even if the tumor appears small on imaging, microscopic tumor cells have already spread into nearby brain tissue. Under the microscope, you will see increased cellularity compared to normal brain tissue.
Normally, the brain has relatively few visible nuclei because neurons and glial cells are lightly scattered, but in diffuse astrocytoma, the number of cells is significantly increased.
Aywa, the nuclei are irregular in shape, enlarged, and hyperchromatic, meaning they stain darker due to increased DNA content. This nuclear atypia is one of the key diagnostic features of diffuse astrocytoma.
Another very important detail is that we see very limited mitotic activity, and we do not see necrosis or endothelial proliferation.
The absence of necrosis and endothelial proliferation is critical because their presence would upgrade the tumor to a higher grade. So if there isn't any necrosis and endothelial proliferation, the tumor is classified as grade 2.
This is where progression becomes important.
Mbala, diffuse astrocytomas rarely remain stable forever. Over time, they accumulate additional mutations and progress to higher grade tumors. This progression pathway moves from grade 2 diffuse astrocytomas to grade 3 anaplastic astrocytoma, and eventually to grade 4 glioblastoma.
So to sum up diffuse astrocytoma, which is grade 2, it has increased cellularity. Now, let's move into anaplastic astrocytoma, which represents grade 3 astrocytoma.
Grade 3 or anaplastic astrocytoma represents a clear progression from grade 2. If you look at the histopathology of an anaplastic astrocytoma, you can see that the tumor cells are much more densely packed than in the diffuse astrocytoma. But the key is that the nuclei are larger, darker, and more irregular. This is what we call increased nuclear atypia.
Anaplastic means that the nuclear atypia is pretty bad.
Another major feature seen in anaplastic astrocytoma is increased mitotic activity. Mitotic figures are visible under the microscope, which indicates that the tumor cells are actively dividing. This increased proliferation is one of the defining features that upgrades the tumor to grade 3.
Oh, so unlike what we said in the diffuse one, which had very limited mitotic activity, this anaplastic one has a lot of mitotic activity. That's how we know it's grade 3 now, the mitosis.
Yes, exactly. And again, just like the diffuse, there is still something missing in the anaplastic.
Still no necrosis or endothelial proliferation.
Yup, because those are the key features that define the next and most aggressive grade of astrocytoma, grade 4 astrocytoma, aka glioblastoma.
Glioblastoma is grade 4 astrocytoma, and it represents the highest level of malignancy.
This is usually a large infiltrative tumor with areas of hemorrhage and necrosis. The tumor appears irregular with regions of yellow discoloration, which represent necrotic tissue. There are also areas of hemorrhage which appear as dark red regions.
Necrosis and hemorrhage reflect a very aggressive tumor.
Those two things relate to two microscopic features that we have been waiting for a long time.
Necrosis and endothelial proliferation.
Yes, those are the two key features of glioblastoma or grade 4 astrocytoma.
Okay, let's break down each one now.
Necrosis occurs because the tumor grows so rapidly that it outgrows its blood supply. As a result, portions of the tumor tissue die.
Simply because there isn't enough blood to feed the rapidly growing tumor.
Surrounding these necrotic areas, we see a very characteristic pattern called pseudopalisading necrosis. This means that the tumor cells are arranged in rows around the necrotic area. These rows of cells look like a fence or a palisade surrounding the dead tissue. This pseudopalisading pattern is a hallmark feature of glioblastoma.
Okay, and the next feature is endothelial proliferation.
This just means that you see a bunch of abnormal blood vessels forming within the tumor. These vessels appear thick, irregular, and multilayered.
Is this because the tumor is trying to make its own blood supply?
Yeah, pretty much. Endothelial proliferation is the tumor's attempt to create a new blood vessels to support its rapid growth. This process is known as angiogenesis.
And, as we previously said, if you see necrosis and endothelial proliferation, the tumor is automatically grade 4 astrocytoma, aka glioblastoma.
One of the most striking features of glioblastoma is its ability to spread across the corpus callosum. You will see tumor tissue extending from one cerebral hemisphere to the other.
Glioblastoma crosses the midline.
This creates a classic butterfly appearance. Because this tumor is so invasive, it can seed into the CSF and create distant lesions in the spine.
That makes glioblastoma extremely difficult to remove surgically.
Yeah, even if surgeons remove the visible tumor, microscopic tumor cells remain behind. That's why glioblastoma has a high recurrence rate.
We said that grade 1 pilocytic astrocytoma occurs mostly in children. What about grade 4 glioblastomas?
Glioblastomas typically occur in adults between the ages of 50 and 60. Patients often present with headaches, seizures, neurological deficits, or cognitive changes. Because the tumor is so aggressive, symptoms progress rapidly.
And the prognosis is not very good, unfortunately.
Ewa, despite the treatment, the prognosis is very poor. Median survival is approximately 15 months.
We have another type of glioma known as gliomatosis cerebri.
This tumor is characterized by diffuse infiltration of large portions of the brain, sometimes even involving multiple lobes. There is no single discrete mass. Instead, tumor cells spread extensively throughout the brain.
This widespread infiltration makes treatment extremely difficult.
Because there is no single tumor mass, surgical removal is not possible, and this tumor behaves like a high-grade glioma.
There's one more type of astrocytoma called pleomorphic xanthoastrocytoma.
This tumor typically occurs in children and young adults. The tumor cells have a very unusual appearance.
Unusual name and unusual appearance.
The name actually comes from the appearance. The cells are pleomorphic, meaning they vary dramatically in size and shape. Some cells appear extremely large and bizarre. That's why we call it pleomorphic. Within the tumor cells, you will also see lipid accumulation. These lipid-filled cells give the tumor its xanthomatous appearance.
Ah, that's why we call it xanthoastrocytoma.
Exactly. Luckily, although it sounds scary, these tumors are often low-grade because they lack necrosis and mitotic activity.
Alright, we just finished the largest group of gliomas, the astrocytomas. Now, let's examine a tumor arising from another type of glial cells, oligodendroglioma.
Oligodendrogliomas are tumors derived from oligodendrocytes or their precursor cells.
Oligodendrocytes are glial cells responsible for producing the white matter in the brain. Their main role is to form myelin, which insulates neuronal axons and allows rapid electrical signal transmission.
In terms of frequency, oligodendrogliomas account for about 5 to 15% of all gliomas. So they're not the most common glioma overall, but they represent a very important and distinct subgroup. These tumors most often occur in adults, particularly in the 4th and 5th decades of life, so typically patients are in their 40s or 50s at diagnosis. There's also a clear gender difference. Oligodendroglioma are more common in males than females, with a male-to-female ratio of approximately 2 to 1.
Is this tumor usually in the cerebral cortex or somewhere else?
Oligodendroglioma is usually in the cerebral hemispheres, especially in the frontal and temporal lobes.
Oh, yeah. We said adult tumors are usually supratentorial.
It's also important to remember that they arise within the brain parenchyma itself, meaning they are intra-axial tumors. Because of their location in the cerebral cortex, one of the most common clinical presentation is seizures. The tumor disrupts normal cortical electrical activity, leading to abnormal neuronal firing.
Oligodendrogliomas are also highly infiltrative tumors, right?
Unfortunately, yes. They may appear relatively well circumscribed, but at the microscopic level, tumor cells infiltrate surrounding brain tissue. This infiltrative behavior makes complete surgical removal difficult. Oligodendrogliomas also have the ability to spread through the cerebrospinal fluid.
Similar to glioblastoma.
Yes, they may metastasize distantly within the CNS, particularly through the ventricular system and subarachnoid space. This process is called CSF seeding. So even though oligodendrogliomas often grow more slowly than glioblastoma, they are still capable of widespread dissemination within the central nervous system.
What do these tumor cells look like?
They have a pretty classic appearance under the microscope. They look like fried eggs. Do you like fried eggs, Lachize?
Sure.
The tumor cells appear as round, regular cells with centrally located nuclei. Surrounding each nucleus is a clear halo of cytoplasm, giving each cell the appearance of fried egg, with the nucleus representing the yolk and the clear cytoplasm representing the egg white. This fried egg appearance is very characteristic for oligodendroglioma, and you should really remember it for your exams.
This clear halo is just empty appearing spaces within the cytoplasm. These spaces are due to artifacts from tissue processing.
Yup. Another extremely important microscopic feature of oligodendroglioma is the delicate network of anastomosing capillaries. They have this fine branching network of blood vessels running throughout the tumor. These capillaries form an interconnected pattern supplying blood to the tumor cells.
I've also heard of something called perineuronal satellotosis.
That's when the tumor cells infiltrate the cerebral cortex and collect around neurons. Under the microscope, you can actually see tumor cells clustering around individual neurons, almost like satellites orbiting a planet. This just tells us that the tumor is invading normal brain tissue.
So, the key for oligodendroglioma on histopathology is the fried egg appearance, the perineuronal satellotosis, and the delicate capillary network. Okay, now let's zoom out to look at the gross features.
Grossly, oligodendrogliomas often appear as well circumscribed masses, even though they are infiltrative microscopically. They are commonly located in the cerebral hemispheres, especially the frontal and temporal lobes, just as we mentioned earlier. The tumor tissue typically appears gelatinous and gray in color. This gelatinous texture reflects the tumor's cellular composition and extracellular matrix. These tumors also contain cysts, which are fluid-filled spaces within the tumor. In addition, localized hemorrhage may be present within the tumor. And finally, a very important feature is calcification.
So Zubda, oligodendroglioma is usually a well-circumscribed, gelatinous, gray mass with cyst and calcifications. Can we see those calcifications in histology?
Yeah, they appear as dark, granular deposits scattered throughout the tumor tissue. You can also see the calcification on imaging, especially CT scans. They appear as bright, dense areas.
So, if you see a brain mass on CT with calcification, you can safely suspect oligodendroglioma.
بالضبط.
Do we have any molecular markers we should know about?
The most common genetic findings are mutations in the IDH1 or IDH2. Remember what we said about these mutations?
Yes, they are associated with better prognosis compared to tumors without them.
Exactly, so IDH mutations in oligodendroglioma is a good thing. In addition, it may have deletions of portions of chromosomes 1p and 19q. These deletions typically occur together as a co-deletion, meaning both chromosome segments are lost simultaneously. This 1p19q co-deletion is seen in up to 80% of cases. This molecular finding is also associated with better response to treatment and improved prognosis.
That was it for oligodendroglioma. Now, let's move to the last type of glioma, which is ependymoma.
This tumor arises from the ependymal cells, which are specialized glial cells that line the ventricular system of the brain and the central canal of the spinal cord. These cells normally form the epithelial lining that helps regulate the circulation of CSF. So when these cells undergo neoplastic transformation, the resulting tumors tend to arise in a direct association with ventricular structures.
And this relationship with the ventricular system is one of the most important features of ependymoma, both anatomically and clinically.
One of the most important epidemiologic aspects of ependymomas is that they show a bimodal distribution based on age and location. In children, ependymomas most commonly arise in the fourth ventricle. This is located in the posterior fossa near the cerebellum and brainstem. Because of this location, pediatric ependymomas often present with symptoms related to obstruction of CSF flow. In adults, however, ependymomas are more commonly found in the spinal cord.
So, ependymoma in children is an intracranial tumor, especially in the fourth ventricle, while in adults, it's a spinal cord tumor.
Because ependymomas arise from the ventricular lining, they often grow into the ventricular cavity itself. As the tumor enlarges, it can block the normal flow of the cerebrospinal fluid.
This leads to obstructive hydrocephalus, which means accumulation of excess CSF within the ventricles, increasing the intracranial pressure.
Yes, and the symptoms of increased intracranial pressure are very characteristic. Patients may develop headaches, nausea, vomiting, and altered consciousness. In very young children, hydrocephalus may also cause enlargement of the head if the skull sutures have not yet fused.
What does the tumor look like?
The tumor appears as a solid mass within the ventricular system. It often projects into the ventricular cavity. It may appear soft, gray, or reddish depending on its vascularity and cellular composition. In some cases, areas of cystic degeneration or hemorrhage may also be present.
And because it's in the ventricular space, it physically blocks the normal CSF pathway. Okay, let's zoom into the microscopic features of ependymoma. It has these perivascular pseudorosettes.
This is one of the defining histologic features of this tumor. In a pseudorosette, tumor cells are arranged radially around a central blood vessel. This is unlike true rosettes, where they surround an empty space. The cellular processes of these tumor cells extend toward the central vessel wall. This creates a spoke-like arrangement, almost like the spokes of a wheel radiating outward from the central vessel.
Remember, the ependymal cells from which the tumor originated normally interact with the fluid-filled and vascular structures because they are so closely linked to CSF. That's why the tumor cells have these processes around the blood vessel. Basically, they're trying to imitate their origin. Do they only have pseudorosettes or also true rosettes?
They can actually have both. And as we said, in true rosettes, tumor cells surround an empty central lumen rather than a blood vessel. This lumen represents an attempt by tumor cells to recreate the normal ventricular lining structures, just like their original ependymal lineage.
So to summarize, ependymoma has both pseudorosettes and true rosettes. True rosettes surround an empty lumen, while pseudorosettes surround a blood vessel.
Yeah, but although it can have both, pseudorosettes are far more common in ependymoma.
Since ependymomas are so close to the ventricles, I'm guessing they can easily spread through CSF, right?
Correct. Tumor cells can detach from the primary tumor and travel through CSF pathways. This is what we call CSF seeding, and we actually saw that already with the previous tumors. After seeding, tumor cells may implant in distant regions of the brain or spinal cord.
This type of spread is different from traditional metastasis through blood or lymphatic vessels and is unique to CNS tumors. Any important genes related to this tumor?
One of the key molecular abnormalities involves chromosome 22. Loss of chromosome 22 is associated with ependymoma. This chromosome contains the NF2 gene, which functions as a tumor suppressor gene. So if you lose the NF2 tumor suppressor gene, you lose the tumor suppression and get a tumor.
What grade is this tumor?
Most ependymomas are classified as grade 2 tumors. This means they are malignant but relatively slow growing compared to higher grade tumors like glioblastoma. However, higher grade variants of ependymomas do exist. For example, there is grade 3 ependymoma, which is also called anaplastic ependymoma. This grade shows increased cellularity, nuclear atypia, and mitotic activity. They behave more aggressively and have worse prognosis.
Okay, Kobe. Before we leave ependymoma, we need to talk about the prognosis because it really depends on where it is, how much you can remove, and whether it spreads in the CSF.
The clinical outcome is better for completely resected supratentorial and spinal ependymomas compared with those in the posterior fossa. So if you can fully remove a supratentorial or spinal ependymoma, patients generally do better than when the tumor is sitting in the posterior fossa, where surgery is tougher and the anatomy is less forgiving.
So basically, the prognosis is worse if it spreads through the CSF.
Yes, if tumor cells spread through the cerebrospinal fluid pathways and seed elsewhere, the disease becomes much harder to control.
Does it ever have a good prognosis?
The best case scenario is a younger patient, a tumor that can be fully resected, and a lower grade microscopic profile.
We fully covered glial tumors. Now, we're transitioning into neuronal tumors, which are very different from gliomas because they arise from neurons or from precursor cells that differentiate into neurons, unlike gliomas, which were from the supporting glial cells.
Neuronal tumors may contain mature appearing neuronal cells. That's how you can tell that it's not a glioma. These tumors often occur in younger individuals, particularly children and young adults. And one of the most important clinical features of neuronal tumors is that they commonly present with seizures.
Because neurons are electrically active cells, and when tumor cells disrupt normal neuronal circuits, abnormal electrical activity results.
Astonishingly, one of the tumors in this group is ganglioglioma, which is the most common neuronal tumor of the CNS. Gangliogliomas are mixed tumors composed of both neoplastic ganglion cells and neoplastic glial cells. This dual cellular composition is extremely important diagnostically. Microscopically, you can actually see large, mature-appearing ganglion cells alongside glial tumor cells. Grossly, these tumors often appear as superficial masses and frequently have cystic components. These cysts may contain fluid and contribute to the tumor's mass effect. An important mutation for ganglioglioma is an activating BRAF mutation in approximately 20% of cases. This mutation promotes tumor cell proliferation and is also relevant for targeted therapies.
Another type of neuronal tumor is the central neurocytoma, which is a WHO grade 2 tumor.
This tumor arises within the ventricular system, most commonly in the lateral ventricles near the foramen of Monro. This location explains why patients may present with hydrocephalus, because tumor growth obstructs normal cerebrospinal fluid flow. Microscopically, central neurocytomas consist of uniform round cells with neuronal differentiation and are often associated with delicate neuronal processes called neuropil.
They are grade 2, so not that bad.
You can say that, Neurocytomas are relatively slow-growing and generally have a good prognosis after surgical removal.
Another neuronal tumor is dysembryoplastic neuroepithelial tumor, or, for short, DNET.
This tumor occurs primarily in children and young adults and is strongly associated with epilepsy. It's typically located in the superficial temporal lobe, which explains their strong association with seizures. Importantly, DNETs are low-grade tumors and have excellent prognosis after surgical removal.
Let's move to another group of tumors, which originate from neuroectodermal cells.
We call those embryonal tumors. They are some of the most aggressive tumors in the CNS. As you said, they are composed of primitive neuroectodermal cells. These cells resemble immature precursor cells that have not yet differentiated into mature neurons or glial cells.
Any tumor with immature cells is generally more aggressive, صح?
Bravo!
How do they look like?
Microscopically, these tumors are composed of densely packed small cells with hyperchromatic nuclei. They have a high mitotic activity, meaning rapid cell division.
This rapid proliferation also contributes to the aggressive tumor growth.
These tumors are classified as WHO grade 4 tumors, so you can see that they are highly malignant.
The most common embryonal tumor is the medulloblastoma, which actually accounts for 20% of pediatric brain tumors.
Medulloblastoma arises in the cerebellum, particularly in the midline region called the vermis. This location is extremely important because the cerebellum controls balance and coordination.
So these patients present with ataxia, difficulty walking, and problems with coordination.
Bullseye. Microscopically, medulloblastoma has sheets of densely packed tumor cells. These cells are small, round, and hyperchromatic, meaning their nuclei appear very dark under the microscope. This is very little cytoplasm, which reflects the immature nature of the tumor cells.
Oh, so like the high NC ratio.
Medulloblastoma also has a classic feature called Horner-Wright rosettes. These consist of tumor cells arranged in circular patterns around the central neuropil. This indicates primitive neuronal differentiation.
Since they're related to the neuronal lineage, they would have neuronal markers.
Yeah, medulloblastoma expresses neuronal markers such as synaptophysin, neurofilament, and vimentin.
Does it also spread through the CSF?
Yes, medulloblastomas do spread through the cerebrospinal fluid and can show a pattern of spread called drop metastasis. This is when they seed and implant in distant regions of the CNS.
We can divide medulloblastomas into molecular subtypes.
These subtypes have different prognosis. The WNT subtype has the best prognosis. The SHH subtype is associated with mutations affecting developmental signaling pathways. Tumors with MYC amplification, however, have a worse prognosis and more aggressive behavior. These molecular subtypes help guide treatment decisions.
We're done with the embryonal tumors. Let's briefly cover one of the most aggressive CNS tumors, which is the atypical teratoid rhabdoid tumor.
These tumors occur primarily in very young children, often under age 5. They are classified as WHO grade 4 tumors.
How does the tumor look like under the microscope? I think the name is pretty descriptive.
Microscopically, these tumors contain rhabdoid cells, which have abundant cytoplasm and eccentric nuclei, hence the name rhabdoid tumor.
What are the genetic mutations like?
There is a loss of INI1 expression. This loss occurs due to deletion of chromosome 22. This molecular abnormality contributes to tumor development.
And we said this tumor is very aggressive.
You're right, they have extremely poor prognosis.
There's a type of primary CNS tumors that seem kind of out of place, which is primary CNS lymphoma.
Primary CNS lymphoma is lymphoma that started in the CNS. It is most commonly diffuse large B-cell lymphoma.
I don't think this is very common, is it?
Not really. It only accounts for approximately 1% of intracranial tumors. But you should remember that these tumors are strongly associated with immunosuppression, especially HIV infection. They are also associated with Epstein-Barr virus infection. This is a pretty aggressive disease and responds poorly to chemotherapy, unlike peripheral lymphomas.
Can peripheral lymphomas spread to the brain?
Lymphoma originating outside the CNS rarely spreads to the brain parenchyma. But when it happens, the tumor is usually within the CSF or involved in the meninges.
So on biopsy, you just see a bunch of lymphocytes, صح?
بالضبط. Microscopically, the tumor consists of malignant lymphocytes infiltrating the brain tissue.
We have another seemingly random primary CNS tumor, which is primary CNS germ cell tumors.
Germ cell tumors occur in midline brain structures, particularly the pineal and supracellular regions. These tumors arise from germ cells that fail to migrate properly during development.
Who is actually affected?
90% of cases occur during the first 2 decades of life, so it's mostly in young adults and usually affects people of Japanese ethnicity more than others. The most common type of primary CNS germ cell tumors is germinoma, which resemble the seminoma of the testes. Luckily, these tumors are highly radiosensitive, so we can treat them with radiotherapy and they have relatively good prognosis.
Okay, we've talked all about intra-axial tumors. There's a very important extra-axial tumor that we have to discuss, and that is meningioma.
This is actually one of the most common primary tumors of the CNS. And what makes meningioma fundamentally different from gliomas is that it does not rise from the brain tissue itself. Instead, it arises from the meningothelial cells, which are specialized cells located in the arachnoid layer of the meninges. These meningothelial cells are part of the protective covering surrounding the brain and spinal cord.
Because of this origin, meningiomas are classified as extra-axial tumors, meaning they arise outside of the brain parenchyma itself. This is important because extra-axial tumors compress the brain rather than infiltrate and destroy brain tissue like gliomas do.
The tumor is usually a well-circumscribed, rounded mass attached directly to the dura mater. This attachment to the dura mater is one of the defining growth features of meningioma.
And it's completely disconnected from the actual brain tissue, isn't it?
Definitely, the tumor appears sharply demarcated from the underlying brain tissue, meaning it has a clear boundary separating it from the brain. Like we said, it creates a compressive growth pattern rather than infiltrative growth. This compression can produce neurological symptoms depending on tumor location.
What does the tumor look like, other than the fact it's attached to the dura?
The tumor itself appears firm, gray-white, and well organized. In some areas, you may also see calcification within the tumor.
Who are the usual patients?
Meningiomas occur most commonly in adults, especially in older individuals. And one of the most striking features is that meningiomas are significantly more common in females than in males. This strong female predominance suggests a hormonal influence. In fact, many meningiomas express estrogen and progesterone receptors. This hormonal sensitivity explains why these tumors are more common in women and may grow more rapidly during hormonal changes.
That's actually very interesting.
An important genetic factor of meningioma is loss of chromosome 22. Chromosome 22 contains the NF2 gene, which encodes a tumor suppressor protein called Merlin. When this gene is lost or mutated, tumor suppressor function is lost. This allows uncontrolled cell growth and tumor formation.
This same mutation is also seen in patients with neurofibromatosis type 2, which explains why patients with NF2 have increased risk of developing meningiomas. Now, let's examine a very classic microscopic feature for meningiomas, which is the world's growth pattern.
Under the microscope, meningioma cells are arranged in circular, spiral-like structures called whorls. These whorls form because meningothelial cells grow in concentric layers around a central point. This pattern is extremely characteristic and is one of the key diagnostic features of meningioma.
So it's kind of like a cinnamon roll.
Don't make me crave it, but yeah, exactly. The tumor cells themselves are relatively uniform in appearance. They have oval nuclei and moderate amount of cytoplasm. Unlike high-grade tumors, there is very little nuclear atypia or mitotic activity in most meningiomas.
So they're basically benign.
Luckily, yes.
Other than the world growth pattern, meningiomas also have samoma bodies.
Samoma bodies are round, concentric calcified structures. They form from progressive calcification of degenerated tumor cells within the whorls. So under the microscope, these calcifications appear as dense, round structures embedded within the tumor tissue. They are one of the hallmark features of meningioma. These calcifications may also be visible on imaging studies such as CT scans, where they appear as dense calcified areas within the tumor.
We said that they compress rather than infiltrate brain tissue, but the symptoms develop gradually, right? Meningiomas grow slowly as far as I know. I mean, they're benign.
Yeah, the slow growth rate allows the brain to partially adapt, so symptoms may develop over a month or even years. Some are asymptomatic and found incidentally by MRI, but others do have symptoms. Symptoms depend entirely on tumor location. For example, tumor compressing the cerebral cortex may cause seizures. Tumor compressing motor areas may cause weakness. Tumors compressing visual pathways may cause visual disturbances.
Most meningiomas are classified as WHO grade 1 tumors because they are benign tumors with slow growth and good prognosis.
Yes, and luckily, these tumors are typically well circumscribed and surgically removed. Complete surgical excision can result in cure in many cases.
Do we have any exceptions?
Unfortunately, we always do. Higher grade meningiomas do exist. Grade 2 and grade 3 meningiomas show more aggressive behavior. These tumors show increased cellularity, mitotic activity, and more invasive growth. These higher grade tumors also have higher recurrence rates.
We finally reached the very last type of tumor you may see in the CNS. This type is actually not primary and instead is coming from somewhere else entirely.
Yup, metastatic tumors. Fun fact, metastasis to the brain is actually the most common brain tumor that we see in adults. They account for 25 to 50% of intracranial tumors.
So brain tumors in adults are usually not even primary.
Yeah, the most common sources of brain metastases are cancers originating in the lung, breast, kidney, as well as melanoma and GI cancers. These tumors are mostly seen in the cerebrum and typically appear at the gray-white junction. This is because tumor cells traveling through the bloodstream become trapped in this vascular transition zone between the white and gray matter.
They're usually multiple lesions.
Yeah, if you see multiple lesions in the brain, suspect metastasis right away.
Alright, Kobe, this was a loaded episode. Firstly, we started by establishing that CNS tumors follow their own rules. Unlike tumors elsewhere in the body, they correlate strongly with age and location. They usually don't have premalignant stages, and even benign tumors can cause severe damage simply because the brain is confined within the rigid skull. That means compression and mass effect can be just as dangerous as malignant invasion.
Exactly. One of the first diagnostic anchors we emphasized was age and location. In children, most CNS tumors arise in the posterior fossa, especially the cerebellum, while in adults, tumors are more commonly found in the cerebral hemispheres. This alone helps narrow the differential diagnosis before you even look at histology.
Then, we connected that to imaging. MRI is the most important imaging modality because it also allows us to see tumor location, size, and relationship to surrounding structures. We also explained the distinction between intra-axial tumors, which arise within the brain tissue, and extra-axial tumors, which arise outside the brain, such as meningiomas.
And even though imaging gives us clinical clues, we emphasize that the histopathology is the definitive diagnostic tool. You need tissue samples to confirm tumor type, determine grade, and identify molecular features that influence prognosis and treatment.
Once we built that framework, we moved into gliomas, which are the most common primary CNS tumors. These tumors arise from glial cells and typically express GFAP, confirming their glial origin. Grading was a major focus because glioma grading predicts behavior and prognosis.
We started with pilocytic astrocytoma, which is a grade 1 tumor seen in many children. It's typically well circumscribed, often cystic, and has classic histologic features like rosenthal fiber and eosinophilic granular bodies. Because it's localized, surgical removal often leads to excellent outcomes.
Then, we moved to diffuse astrocytoma, which is grade 2. Unlike pilocytic astrocytoma, this tumor infiltrates surrounding brain tissue, making it harder to completely remove. Microscopically, it shows increased cellularity and nuclear atypia, but lacks necrosis and endothelial proliferation.
As tumors become more aggressive, they progress to anaplastic astrocytoma, which is grade 3 showing increased mitotic activity and greater atypia. And finally, glioblastoma represents grade 4, the most aggressive astrocytoma.
Glioblastoma have defining features like necrosis and endothelial proliferation, and it often spreads across the corpus callosum, creating the classic butterfly appearance on imaging. These tumors grow rapidly and have very poor prognosis.
We also covered oligodendroglioma, which typically arises in the cerebral hemispheres and presents with seizures. Microscopically, these tumors show uniform cells with clear cytoplasm, producing the classic fried egg appearance, along with delicate branching capillaries and calcifications.
And we emphasize the importance of molecular features like IDH mutations and 1p19q co-deletion, which are associated with better prognosis and treatment response.
Next, we discussed ependymoma, which arises from the ependymal cells lining the ventricles. These tumors can obstruct CSF flow, leading to hydrocephalus. Microscopically, they also show perivascular pseudorosettes, where tumor cells surround blood vessels.
After gliomas, we moved into neuronal and embryonal tumors. Neuronal tumors like ganglioglioma and central neurocytoma show neuronal differentiation and often present with seizures.
Embryonal tumors like medalloblastoma are highly malignant pediatric tumors composed of primitive cells. These arise in cerebellum and often spread through the CSF. Histologically, they show small hyperchromatic cells and homocyte rosettes.
We also discussed the atypical teratoid rhabdoid tumor, which is extremely aggressive and associated with loss of INI1 tumor suppressor function.
Then we covered primary CNS lymphoma, which is usually diffuse, large B-cell lymphoma and is often associated with immunosuppression and Epstein-Barr virus infection. Then there were the germ cell tumors, which arise in midline structures like the pineal gland.
We then moved into meningioma, one of the most common extra-axial tumors. These tumors arise from meningothelial cells and are attached to the dura. They compress the brain rather than infiltrate it.
Microscopically, meningiomas show whorled cell patterns and samoma bodies, which are concentric calcifications. Most are benign, but their location can still cause serious neurologic symptoms.
Finally, we discussed metastatic tumors, which are actually the most common brain tumor in the adults. These often appear as multiple lesions at the gray-white junction and commonly originate from lung, breast, melanoma, kidney, or GI cancers.
So, the key to understanding CNS tumor is integrating age, location, imaging, histology, and molecular findings, recognizing patterns like rosenthal fibers, fried egg cells, pseudorosettes, samoma bodies, and necrosis allow you to identify tumor types quickly.
That's all for today's episode. Thank you for joining us, Kobe.
Thanks for having me.
And thank you all for listening to PodBites. Until next time. Let's wrap up by summarizing everything we talked about. Firstly, we started
ما في firstly.
أنا أضفتها من عندي.
قول we started بلا فلسفة.
Firstly, يا الله كربس كالوسم يا الله